Hi, welcome to the gout presentation, which is on page 547 of your book. Oh my goodness, look at that picture of that toe. That looks pretty bad, right? This is the metatarsophalangeal joint, which we call the big toe. Could you imagine saying to someone, you stepped on my metatarsophalangeal joint? Anyway, this is the place that gout most likely occurs. It would be a nice place to write a case presentation about, a very painful swollen toe you should recognize as a gout case. But gout can appear in other joints. You can see patients sometimes that have such severe gout that the uric acid is just crystallizing in tissues that are outside the joint. But that's the most common place to see it. Okay. Here's what's happening here. You've got urate crystals. Uric acid is called urate here, and it's forming. And then this is a bone erosions and tophus, which is a kind of a bony outgrowth in a patient with very severe gout. So that's very painful. And the classic symptoms are inflammation. This is a very inflammatory condition, which is why we are using anti-inflammatory agents. We're not using Tylenol, we're using NSAIDs or steroids primarily. So let's underline that. And the pain is quite severe. There's this old saying about gout that even the pain, even the pressure from a sheet will be excruciating if it's resting on that joint. And you'll see patients come into the clinic, and because they cannot put weight on that toe, they're being held up by like two people hobbling along, and their face looks in agony. And the outside will be red. They can't move, very swollen. It can also affect other joints, as I said. Here's gout in crystals. You can see the lumps in someone's fingers. Okay, I want to go through what happens here, and this is on page 548 of your book. Then we'll hop back to 547. What happens is that people get purines from their diet, and remember that purines are one of the base pairs of DNA. So you have purines and pyrimidines. And purines are here, and they are metabolized by several steps into uric acid. And uric acid is renally excreted, so it's going out into the toilet bowl through the urine. And these couple of steps here are metabolized. This step, let me erase this so that you can see clearly. These two steps, from hypoxanthine to xanthine and from xanthine to uric acid, are metabolized by the enzyme xanthine oxidase. And if you look in your picture here, it lists the two drugs that block xanthine oxidase, allopurinol and febuxostat. So that would be a good mechanism of action to keep in mind. Now, if you block this enzyme, what you end up with is hypoxanthine and maybe some xanthine, and that doesn't cause any problems. It's not going to crystallize or anything like that. So because uric acid is renally excreted, you can imagine that a primary risk factor for gout will be some degree of renal impairment. But it's not the only risk factor. So let's look at some of the risk factors. Males get gout more often, but boy, there's a lot of little old ladies that get it too. It's just more often. Being overweight is a huge risk factor, but you'll see some skinny patients with gout. Excessive alcohol consumption is usually present, not always, and particularly beer. Hypertension is critical. High blood pressure is a big risk factor, as is chronic kidney disease. Lead intoxication can cause gout even without CKD, and then elderly, because you get this combination. So they're almost always, I've never seen a patient with gout who wasn't quite elderly. Now, to reduce the risk of recurrent gout attacks, you can try to make dietary changes because the purines are coming from what you drink or what you eat. Now, the gout guidelines came out towards the end of 2012, and there weren't guidelines for, I don't know, a decade or so before that. So these guidelines are important, and the reason that they came out is because there were two new very expensive drugs that we're going to look at in a minute, which led to the need for how do you use these drugs. And so we ended up with a committee being formed and then a guideline. And so this is the current research that's in the 2012 guideline. I think it came out in October, November of 2012. It's listed at the front here. So there's some changes here from what you may have learned in school. And first of all, let's look at what's thought to increase the risk dietary. Organ meats were always known to have risk. High fructose corn syrup is kind of new and is very unhealthy anyway. Alcohol we knew about, but this is new. Servings of fruit juice, table sugar, sweetened drinks, and desserts. Salt, beef, lamb, pork, and seafood with high purine content. Not all seafood is high purine content, but what is sardines and shellfish should be limited. They're considered to be high risk. Notice that some of this is healthy though, so it's not saying don't eat it, it's saying limit it. Low fat dairy products, vegetables, hydration, that means keeping yourself well hydrated, the patient, drinking water, weight loss, and exercise are encouraged and reduce the risk for gout attacks, and they do. Okay, let's see. So hydration, weight loss, and exercise. Yeah, all important. All right. Now, that is listed, if you want to look where it's highlighted, to highlight it, those are under the risk factors on the bottom of page 547. Let's look at the parameters for gout. And first, let's take a look at the medications that can increase uric acid. So diuretics do. Thiazides are used for blood pressure, so maybe the patient doesn't need to be on a thiazide. Maybe they could be on an ACE, an ARB, a beta blocker. Loops, when they're used, you have to use them. Yeah, do they increase uric acid? Yes, but the patient probably has heart failure and you need the diuresis from the Lasix. Niacin is contraindicated in severe gout, which is interesting to me because I've never seen gout that wasn't considered severe once the patient had a gout attack. It'll be considered severe to the patient. Now, if you have an elevated uric acid, so uric acid is from around 2 to 7, you could have this elevated for years without having a gout attack. Let's say you could even have 13. And we do not treat until they have a gout attack. So this is called asymptomatic hyperuricemia. And the way you might be able to prevent a gout attack for a while is maybe the patient could get off of one of these drugs. So you'll have to think about that. But eventually, unless the patient passes away from something else, they will get a gout attack because the uric acid is high. It gets worse as the patient gets worse, and eventually will become so saturated that the slightest stress on the joint will cause crystallization. And you see that, like patients will tell you, I stubbed my toe and then I got gout. In other words, the uric acid was very saturated in the joint, but until there was a stress to that joint. But other patients, who knows what, it crystallized while they were sleeping. Okay, so niacin, if they're on it and they haven't crystallized yet, maybe they could be using something else. Aspirin in higher doses, so get them on a different analgesic. Don't pick a salicylate, something else. Pyrazinamide, which if you're using it, you probably have to use it, so that would be a tuberculosis patient. Cyclosporin and tacrolimus, if you're using it, you have to use it, right? So you can't stop a transplant drug, for goodness sakes. This is not topical. This is systemic. Okay. And I mentioned this lab parameter. The reason it says approximately is because there's different levels for males and females, but it's approximately this. But you don't get gout when it's a little above this. There's no gout at 8.3. There's gout at higher levels, and the higher levels, like I mentioned, hang around for a while and are not treated, except that you might change drugs or food intake, but you wouldn't use drugs because the drugs are toxic. So we're holding them until the patient actually crystallizes. Okay, now if you look under the pharmacologic therapy on page 548, it says the goal of treatment is to treat acute attacks and prevent attacks in the future and reduce the uric acid levels. So this is a condition where you're going to have prophylactic agents, very similar to like migraine treatment, prophylactic agents, and these are very different than using agents for the acute attack. The acute attack is primarily NSAIDs, and what's used most commonly would be steroids. NSAIDs might just not be strong enough agents. There's a drug called colchicine that we're going to use, and that is used for acute attacks as well. Now, the prophylactic agents are the agents that lower uric acid. But the situation here is that the prophylactic agents are so potent that they can lower uric acid so fast that it actually can disrupt the equilibrium in the joint and cause precipitation of an acute attack by lowering the uric acid. And so you sometimes will see colchicine or NSAIDs, not steroids, they're too toxic, leave them for the acute problem, used for a period at the beginning of the prophylactic agent. So typically the prophylactic agent is allopurinol, and you'll see either this or this used for months, and then it stopped when you're no longer at risk of an acute attack. Okay, now, if you look on page 548 in the middle, it also says any of these drugs can be supplanted with ice. Patients use ice pack on the joint, and that helps quite a bit as well. Okay, let's look at the acute gout attack treatment. So we're not lowering uric acid right now. We're treating an acute attack. The oldest drug here that's used is called colchicine. All the colchicine generics were, the FDA forced them off the market, and the only one we have now is this branded colchicine called Colchris. And the dosing for this is important because this drug is very toxic if you overdose it. So it's 1.2 milligrams orally. Now the only way it comes is here. So this is clearly half of 1.2. These are small tablets. And so the patient is taking 2 of them. And then they can have one more. So they have 1.2. And then they can add one more. So the total dose here is going to be 1.8 milligrams of colchicine for an acute attack. Let's read what it says under the dose. It says this regimen can be followed by 0.6 twice a day, starting 12 hours later. So you give the 3, you give 2 of the 0.6, an hour later you give another one. Then you're done. Then you can go on to the 0.6 BID until the account is resolved. But when you do that, oh my goodness, your patient is going to have loose stools to the point that it might even be like a baby with anal irritation from the liquid just coming out. And you might want to recommend like a Decidin or something like that. If they're often when you do this, the patient will tell you they're starting to feel very weak with cramping, and that might be a reason to stop using them. Now, if you look at the contraindications, this is a 3A4 substrate. You cannot overdose it, so it's contraindicated with a strong P-glycoprotein or 3A4 substrate inhibitors. It also is pumped out of the body by the efflux pump P-glycoprotein, so you can't block that pump with a strong inhibitor. Okay, The clearance is decreased with either renal or hepatic impairment. Look at these side effects. About 80% of patients are going to complain of nausea and diarrhea, or they're going to say, my stool is coming out very liquidy. And it's only recommended to use colchicine if you're able to get to the physician to get a prescription within 36 hours of onset. Now, the first time the patient presents with a acute gout attack, if colchicine is recommended, they are giving the patient colchicine for further gout attacks, which is why it's critical. They don't just give, 6 or 7 tablets, they give more. And so it's critical for us to go through and make sure the patient knows how to take this properly. Okay, now NSAIDs are used. We know about those from the pain lecture. You can go back. They are used. But I want to point out to you that when you're treating inflammation, you're using high doses and then you're cutting down. So these doses are not your typical doses. Let's take a look at the Indocin. It's dosed 50 TID. Naproxen, you actually start with 750 times 1, then you cut it down. Sulindac might be a little bit safer in renal impairment, and these patients are generally renally impaired. So Sulindac has the indication for gout use, but naproxen and Indocin have the indication for gout use. Celebrex is used commonly, but it's off-label. You could really use any NSAID, actually. Okay, now steroids are being very commonly used for gout, and they can be either orally, or what's done sometimes is to inject the steroid into the joint. That's the brand of the colchicine, Colchris, and that's just the colchicine side effects. Before we get to the injection, I wanted to show you the dosing of a Medrol dose pack. Methylprednisolone comes in the Medrol dose pack. Dexamethasone comes in the Decadron dose pack. Why do we use this? This is starting off at a high dose and then titrating it down. This isn't a steroid titration because of you're weaning the patient off because they've been on steroids for weeks. No, it has nothing to do with that. This is starting high and cutting down the dose because that's the best way to treat acute inflammation. So it's very different. But when you start off on these relatively high doses of steroids, they can raise blood pressure, they can raise blood sugar, and they also make people kind of agitated and a little bit jumpity and sometimes obnoxious. So you just have to counsel about that, and that's due to the high dose here, and then they're cut down. Okay, now you can also inject into the joint, and that may be done. So you can see here, they're injecting a steroid right into the joint to reduce the inflammation. You have to be careful because you don't want to damage the joint. You can't do this too often or you will damage the joint. But you wouldn't have systemic side effects from the steroid either because the steroid stays localized in the joint capsule. Okay, the steroid side effects are discussed in some detail in the asthma section. These are acute side effects, not chronic. We don't put people on chronic steroids for gout. That's ridiculous. That would be ridiculous. What you do is you lower the uric acid level with a drug like allopurinol so that they don't need to be on chronic medication. Look at the box, please. On the bottom of page 550, this is the prophylactic treatment. Allopurinol is the primary drug used. It's a very old, inexpensive drug. The brand name is called Xyloprim, and it is a xanthine oxidase inhibitor. Look right above the box what it says there. It said use colchicine at a daily dose, so it's once or twice daily, or NSAIDs for the first 6 months, at least, some will get it a little longer, in order to prevent an acute attack because of the lowering of the uric acid level. So keep that in mind. And the dose here is 50 to 100 milligrams daily. You start, but you're definitely not going to use 100 milligrams daily if the patient has renal impairment. So if you look at the right side under notes, it says if they've got a significant renal impairment, we start lower. There's no reason not to start lower. What's going to happen is you're going to increase the dose to a normalized uric acid level. So you want it below 7.2. And most patients are on 100 milligrams a day, but a patient with renal impairment might be taking 50. The range is 50 to 200. This is very different than the doses of allopurinol that are used for tumor lysis syndrome secondary to chemo drugs, because in that case, you're lysing open the tumor cell. They're rapidly dividing cells, right? So they are full of DNA. What is DNA made of? Purines and pyrimidines. So all these purines and pyrimidines get dumped in the blood. There is a lot of xanthine oxidase in the blood. It rapidly produces uric acid, and the patient who's never had gout before can get acute crystallization because of this huge sudden rise in uric acid levels. And so what happens is if you're using one of these lysing drugs, then you end up taking much higher doses of allopurinol, but that's a chemo-related thing, and it has nothing to do with the 50 to 200, usually this, for your gout patients who have gout because of a chronic condition. Now, under the warnings for allopurinol, allopurinol can occasionally cause hypersensitivity reactions, including severe rash. I've seen this once with the oncology dose. Now, you can test for the HLA-B 5801 allele, and that would indicate, let me just show you that. That would indicate whether the patient was at high risk here. And it's recommended in Koreans with the stage 3 or worse CKD, all Han Chinese and all Thai people, because if they're positive for this, they're going to be much higher risk for the hypersensitivity syndrome, and that could be fatal. This is not a mild rash, of course, and so you wouldn't want to use it if they were positive for this specific allele. But we don't test in anyone. It's these groups. Okay, now allopurinol can also is irritating to the liver, so we monitor liver enzymes as well. Now, febuxostat, Uloric, is actually recommended now in the gout guidelines, so it's allopurinol or febuxostat. Allopurinol is a heck of a lot cheaper than febuxostat, so there are many formularies that are not going to have febuxostat except with specific contraindications. But the rheumatologist wrote the gout guidelines, and they like this drug. And why did they like this drug? Well, because it's got a reduced risk for this hypersensitivity reaction. It would be the one you would go to in the HLA positive patient. And you don't have to worry about dose reducing for renal impairment. Most of these patients have renal impairment, but it does cause, it is irritating to the liver. You do need to monitor for liver damage, and of course it's much more money, and it cannot be used with azathioprine or mercaptopurine, contraindicated with those drugs. Please be sure to monitor liver. And they're watching the drug to see if it increases clotting risk, because there's been cases and it may do that as well. Now, the uricosuric is increasing the excretion of uric acid. These are old drugs, probenecid. Probenecid comes with colchicine in this combination product, but these require adequate renal function. These patients generally do not have adequate renal function, whereas allopurinol or febuxostat work with adequate or inadequate renal function. Probenecid does not. Probenecid is used actually sometimes when you want to block renal clearance. Here, probenecid is increasing the renal clearance of uric acid, but probenecid also is used to block beta-lactam excretion. So you see that sometimes in weird conditions like your neurosyphilis. Keep in mind that it requires adequate renal function, and you can't give it with concomitant aspirin therapy. With uric acid, kidney stones can be made out of calcium. In this case, it's specifically uric acid kidney stones. You cannot initiate it during an acute attack, and you have to watch out for hemolytic anemia. So with a G6PD deficiency, probenecid is a do not use drug. Now, the last one in this category is a drug that we're not involved with, so just know what the name of it is. It's because it's an IV medication. It is only for your very refractive gout cases. It's called Krystexxa, and that is an expensive injection with high risk of anaphylactic reactions, requires pre-medication for that. So just know it's for refractive cases. It's an injection. It's $6,500 for each injection. So it is in the guidelines only for refractive cases. Okay, that's it for this topic. I want to say one thing. When you give out a drug that, like allopurinol, that could cause Stevens-Johnson, including for your tumor lysis patients, please tell the patient. A mild rash is one thing. A severe rash, which often starts here and spreads, they look very bright red. They can happen very quickly. They could start anywhere, but it often spreads out from the trunk. Don't tell the patient that. Just the bottom line is, if you have a rash and it looks serious, you need to be seen right away. Not call the doctor and the doctor calls back tomorrow if you're lucky. The counseling is you need to be seen right away because it could develop into a very severe rash very quickly. So don't take a rash if it appears from this drug lightly. Thanks for listening to the Gout Lecture.